Center for Global Health in the College of Medicine. Thank you for joining us for this special lecture today. We celebrate Cancer Day, as every year at the beginning of February. And we decided to have, to honor this day by actually having a speaker, a special speaker for today. And I will spend a few words on him. Before I want to take a couple of minutes to inform everybody about next month, actually lecture. The colloquium that all the College of Medicine and other partners on campus organize. For next month, we have a special speaker as well, and he's going to be Dr. Leonardo Cubillos, who is the director of the Center for Global Mental Health Research at the National Institute of Mental Health. We are extremely honored and glad to have him as a speaker because of his experience, not only in mental health, but also in health policy. He worked before joining Dartmouth Medical School, where he's right now. He also was at the World Bank in Latin America. He has an expertise in economics of global health as well. And he was advisor to the Ministry of Health of Colombia before that. So we are looking forward to next month's speaker. Next month lecture will be on March 2nd, still at 12 o'clock Wednesday. So today we decided to, as I said before, to honor a Cancer Day by having someone on the ground to explain and to tell us about the challenges of treating patients with cancer in a low middle income country. And I'm particularly delighted to have Dr. Bishesh Poudyal, who's professor of hematology at Civil Service Hospital in Kathmandu in Nepal, and he's also a faculty professor of medicine at the National Academy of Medical Sciences in Kathmandu. That is the oldest medical school in Nepal. So the relationship with Dr. Poudyal is 10 years long, and you will hear from his talk about the challenges that actually allowed us to develop together some work in building, in treating patients with blood cancer. But also, I have to say, as main way to introduce Dr. Poudyal, that actually I have learned a lot from him, and I've learned how resilience and human skill really in global health are probably the most important investment that you can do. And he's the proof of how basically by himself has been able to build a program and a fellowship program, as well as a bone marrow transplant program in a public hospital with little money and little revenues, and a very impactful work. I think that there are lessons to be learned in treating cancer in low-income countries, and I think that some of those lessons are very effective also in here. So we could learn more things that we can apply to our own practice in the United States. So because of actually Dr. Poudyal should be connected with us. It's midnight at his in Kathmandu, but he was kind enough to be available. But we asked him to record his lecture just in case the internet would have not been so nice to us. So I will start the video that actually he sent, and I look forward to having questions afterwards via the chat. So please use the chat, and we'll talk to Dr. Poudyal. I hope technical things will not.
I work in Civil Service Hospital, Kathmandu, Nepal. In a coming 30 to 40 minutes, I'll be discussing about challenges in blood cancer treatment in Nepal. Let me start with the country introduction first. Nepal is a tiny country sandwiched between India and China, and known to the world because of Mount Everest and its unique triangular national flag. Nepal has 8 out of 14 mountains in the world above 8,000 meters. Nepal is very well known for the beautiful lakes and its wildlife and Nepal is the birthplace of Lord Buddha. Nepal has a population of 30 million people spread over 147,516 square kilometers. Kathmandu is the largest urban center in Nepal and is the capital city of the country. Although a small country in terms of area, Nepal is home to 126 different ethnic groups speaking 123 different languages. Talking about economy, literacy and life expectancy, 25% of total population lives below the poverty line. Its literacy rate for population above 5 years of age is just under 66%, 75% for males and 57% for females. The life expectancy at birth is 70 years, that is 68 years for males and 71 years for females, according to the recent World Bank data. GDP per capita is below $1,200 US. The healthcare system of Nepal is overwhelmed with infectious and communicable diseases. Nepal spends 5.8% of GDP on healthcare cost. If you compare this with the Western world, it is very low. But if you compare it with the neighboring countries, it's not that bad either. Although the health insurance program has been introduced in Nepal a long time back, the national coverage is very low. Therefore, patients are bound to pay the healthcare expenses from their pocket. It is estimated that there are 50,000 to 70,000 new incident cases of cancer per year. Cancer stands as the third most common cause of non-communicable disease death in Nepal, accounting for 9% of total death. Lung, cervical, breast, stomach and colorectal cancers are the top 5 cancers according to Global Oncology 2020 data. This is a recently published data of trend of cancer incidence, mortality and disability adjusted life years in a cancer patient, and as seen in this slide, the incidence and mortality of cancer patients is increasing every year. So talking about burden of hematological malignancies in Nepal, this is a data published from Civil Service Hospital, and you can see acute leukemia tops the list. The acute leukemia is followed by essential thrombocythemia, polycythemia vera, chronic myeloid leukemia, multiple myeloma, lymphoproliferative disorders, myelodysplastic syndrome, non-Hodgkin's lymphoma, amyloidosis, and Hodgkin's lymphoma. So what are the challenges that we face while managing hematological malignancies in Nepal? So number one challenge is the shortage of healthcare workers. We have very few hematologists, very few hematopathologists, and very few nursing staffs who are trained in hematology and oncology. We have very few diagnostic centers are equipped with flow cytometry, immunohistochemistry, molecular and cytogenetic services. We not only lack dedicated healthcare workers, we also have a shortages of helping hands in our medical field. For example, we have a very few trained biomechanical engineer who can handle our instruments. We had a very bad experience few years back when our HEPA filter system broke down. Our local engineers were not able to fix it, and therefore we had to call engineer from Singapore to fix our HEPA filter system. Another challenge that we face in our day-to-day practice is unavailability of medicines. Our pharmaceutical company does not manufacture chemotherapy and high-end antibiotics. All chemotherapy and most of the antibiotics are imported from India. At times, there are shortages of chemotherapy because of strike, political instability, and various disputes in the border areas. Shortages of blood product is another challenge. This is because we have a very small donor pool or donor percentage. As per international standards, blood donor population must be 1 to 3% of country's total population to meet the demand of blood supply. In our case, it's only 0.5%, and therefore we have a frequent shortages of blood products for our patients. Another challenge is the lack of cancer centers. Most of our treatment centers are located in big cities. Therefore, people are bound to travel a long distance to visit cancer centers. Because they need to travel to different cities, they must rent a place to stay during the treatment, which adds cost. And on top of that, low health literacy and favor of alternative medicine and traditional healers leads to delay in diagnosis and results in poor outcome in our patient. Antibiotic resistance is a major problem in this part of the world, and this is primarily because of lack of antibiotic stewardship. This is our study of antibiotic resistance pattern in patients with febrile neutropenia undergoing chemotherapy in our center, and our study shows the high incidence of multi-drug resistance and extended drug resistance in our study population. In our studies, 66.7% of total gram-negative bacteria were multi-drug resistance. Similarly, 33.3% of gram-negative bacteria were extended drug resistance, and most of the Klebsiella and E. coli were multi-drug resistance. Fungal infection is another challenge. There are reports of high incidence of fungal infection from Asian countries. Recent Indian study reported a high incidence of fungal infection despite use of posaconazole and voriconazole as a prophylaxis in hematological malignancies. And our own study using fluconazole as a prophylaxis for acute myeloid leukemia reported a fungal infection of 65%. Financial toxicity is a major challenge for us. This study was carried out in our center to define financial toxicity in acute leukemia patients. We used 3 parameters to define financial toxicity. Number 1 parameter was asking for the charity from public, and this was present in 94% of our patients. Number 2 was borrowing loans with interest from friends and family, which was present in 88% of our patients. And number 3 was the selling of property, and which was present in 87% of our patients. If 2 out of 3 parameters were present, we defined it as a severe financial toxicity, and it was present in 96% of our patients. Similarly, if all parameters were present, it was defined as extreme financial toxicity, and it was present in 73% of our patients. This survey describes the gravity of financial toxicity in our patient, and this is not a good sign at all. Diagnosis of hematological malignancies and out-of-pocket expenditure for treatment puts patient in lots of stress. We did this study on our patient using NCCN distress score, and to our surprise, 100% of our patients had experienced some form of distress. There are challenges, but that doesn't mean that you have to give up your aim or give up your hope. And as rightly said by Michael Jordan, obstacles don't have to stop you. If you run into a wall, don't turn around and give up. Figure out how to climb it, go through it, or work around it. So, despite these challenges, we are moving ahead with a determination to improve the outcomes of our patient. And one should thank Civil Service Hospital for its contribution for the development of hematology service in the country. Civil Service Hospital is the only center to have a comprehensive hematology and bone marrow transplant facility at present. Civil Service Hospital is the only center to run 3 years fellowship program in clinical hematology and bone marrow transplant. And now Civil Service Hospital is regarded as a tertiary level center for blood-related disorders. And things are improving. As you can see from this slide, on the left is a publication from Pediatric Hospital in 2014. They reported the outcome of pediatric patients treated in their center, and in conclusion they wrote their 5-year complete remission rate was 28.3%. On the right is a data from Civil Service Hospital, unpublished but awaiting a publication. This is a data of pediatric and adolescent ALL patient, and you can see that 5-year survival is above 85% for these patients. Similarly, things have improved for acute promyelocytic leukemia. In the past, patients were dying because of lack of treatment and diagnostic facility, but now 5-year survival of a patient treated in civil service hospital has reached above 95%. Above 90%. So these were possible because of improved level of care and improved supportive care. So how to overcome the challenges? So I strongly believe by doing research and studies that can address our local problem can help us in many ways to overcome our challenges. For example, until recently, only 3 antifungal agents were available for treatment of fungal infection in Nepal. It was plain amphotericin, liposomal amphotericin, and injection voriconazole. Liposomal amphotericin and voriconazole were very expensive, and that's why we were left with no other option than to use plain amphotericin for our patients. Plain amphotericin is known for numerous toxicities like chills, fevers, rigors, acute kidney injuries, and many other adverse events. Therefore, we decided to make our own liposomal amphotericin by mixing a plain amphotericin with intralipid. Intralipid is a lipid that is used in total parenteral nutrition, and to our surprise, it worked. It reduced the infusional toxicity when you compare it with the plain amphotericin, and on top of that, it decreased the incidence of fungal infection and reduce the mortality of the patient. So you can see here in a fluconazole arm, the fungal infection was the rate of fungal infection was 65%. So in our amphotericin arm, with our lipid with plus amphotericin arm, we can see it has decreased to 21.8%. And you look at the mortality in lipid amphotericin arm is 0, but the mortality while using fluconazole as a prophylaxis in AML patient was up to 15%. And this slide shows the 20 days cost of our own lipid amphotericin, and you can see it is very cheap compared to a liposomal amphotericin and voriconazole. Another way to overcome our challenge is not by copy pasting, is by not copy pasting and blindly following foreign guidelines and treatment protocol. And we have learned this from our aplastic anemia patients. We all know that ATG plus cyclosporine is a treatment option for severe aplastic anemia patients who are not eligible for bone marrow transplant. And if you follow the Western literature, the response rate of ATG plus cyclosporine in both pediatric and adult population is above 70%. However, our studies showed a different result. In an adult population, the response rate was above 70%, which was comparable to the Western data, but in pediatric population, response rate was only 35%. This result was an eye-opening experience for us, and based on these results, we stopped prescribing ATG plus cyclosporine to our pediatric patients and rather started to take them for haploidentical transplant if needed. So this is another example of research conducted to address the challenge of bacterial infection in febrile neutropenia patients. In this study, we tried to evaluate the availability of procalcitonin and CRP to predict bacteremia in patients with febrile neutropenia. We were interested in the study because the early detection of bacteremia could enable us to start or change antimicrobial agents. Published literatures are very much divided on the role of procalcitonin in febrile neutropenia, but in our study we were able to show that the procalcitonin is an effective biomarker to predict bacteremia in febrile neutropenia patients. Based on this study, we are conducting another study to look whether procalcitonin can predict the infection with MDR and XDR bugs. Our preliminary data shows if procalcitonin is above 30, chances of MDR and XDR isolation is very high. Our experience with hemophilia is another example of how publication in scientific journal can benefit patients in low-income countries. We all know that hemophilia is a very expensive disease, and therefore we have to rely on World Federation of Hemophilia for a donation of clotting factors for our patient. And for the last 20-25 years, World Federation of Hemophilia is donating us a huge number of clotting factors. And because of the generous donations of clotting factors, we started doing all sorts of complicated surgeries like craniotomy, arthroplasty, and excision of pseudotumors. We reported the outcome of our surgery in Hemophilia Journal, and the donor agencies were very happy with our results. And now they have started donating imicizumab or Hemlibra, a very highly effective medicine for hemophilia A. And now we have 65 hemophilia A patients receiving imicizumab as a prophylaxis. We are the only country after Sri Lanka in South Asia to put patient on imicizumab prophylaxis, and thanks to the donation. And I should really thank WFH for the donation and for having a strong faith on us. And the story doesn't stop here. We are now participating in a gene therapy trial conducted by St. Jude Children's Hospital for our hemophilia B patients. Exploring the cheaper and affordable option without compromising the efficacy of a drug is another way of tackling financial toxicity in a low-income country like Nepal. You can see in our first paper we compared efficacy of haloperidol and olanzapine in the control of chemotherapy-induced nausea and vomiting. Haloperidol was way cheaper than olanzapine when this study was designed. In our study, haloperidol was found to have comparable efficacy, and this helped us to reduce some portion of financial toxicity of our patient. In another paper, we discussed the value of using cheaper alternative medications, herbal medicines like ginger in chemotherapy-induced nausea and vomiting. Ginger is dirt cheap and can be used effectively to treat chemotherapy-induced emesis. And another way to improve a cancer care is through advocacy. In a low-income country like Nepal, low resources are allocated to the cancer treatment. And I think our publication will help government to understand the gravity of the problem and can play a pivotal role in the improvement of cancer care. So the more we publish, the more the visibility, and the more strong our data, more easier for us to convince the government to bring effective cancer care policy in the country. So coming to a bone marrow transplant, we did our first bone marrow transplant in 2012, and we published that in British Journal of Hematology. But soon we realized that there were a lot of challenges. There were a number of challenges. The number one challenge was to win the trust of referring physician and the patients. We realized this was not possible until and unless we have an international collaboration which can help us to strengthen our transplant program. Luckily, we got connected with Dr. Damiano Rondelli from UIC, and to be very honest, he has helped us in many ways. He has mentored us, taught us, and strengthened our program. His frequent visits to Nepal has helped to foster our transplant program here in Nepal, and we are very grateful to him. And this is our paper that got published in Transplantation and Cellular Therapy, and it featured how UIC has partnered with Civil Service Hospital to establish a transplant center. And these are our transplant outcomes, and if you compare that with the rest of the world, if you compare that with the high-income countries, our transplant results are very much comparable to the Western data. And our transplant cost is very low and is cheapest in the world. So if you compare our transplant cost with the neighboring country, we do transplant in a much lower cost. And if you compare our transplant cost with the US, then you will be surprised, because I think in the US the transplant will cost around $250,000 to $500,000. But here in Nepal, we are able to do it in $6,000 to $13,000 US dollars. But if you look back, the establishing a transplant center in Civil Service Hospital was a very complicated procedure. and it was a kind of a nightmare for us. Right after signing MOU between UIC and Civil Service Hospital, two major catastrophic events delayed our project. Number one was the earthquake, which was devastated much of our infrastructures, and more than 10,000 people died during that earthquake. And another one, right after the earthquake, there was an Indian government embargo, and because of these two events, our transplant program got delayed for a year. Despite all these adversities, we were able to start our transplant program in August 2016, and since then we had never looked back. Our transplant program is very well recognized in the world. Last year, Lancet Hematology featured our transplant program, and we are very thankful to Lancet Hematology for this recognition. Recently, we did a study to find out socioeconomic determinants of our transplant patients. In this study, we found three factors were impacting a life after bone marrow transplant in our patients. Number one factor was a distance from civil service hospitals, from the civil service hospital. The most of them had to travel a long distance to reach hospital. Number two was a loss of caregiver job and a loss of income in the household due to a caregiver assistance to the patient. And then number three was a cost involvement in the management of post-transplant complications like cytomegalovirus and expenses related to the blood transfusion. And in the upcoming slides, I will explain how we are trying to mitigate all these complications. We also organized a global BMT conference in Kathmandu 3 years back. 3 years back to share our experience and to learn from our neighboring countries. Our challenges were very much comparable with their challenges in the terms of cost, infection, and lack of healthcare providers, and so on. So then came COVID in 2019, and COVID was a big challenge, but it didn't stop us either. So during COVID, because of national lockdown, patients were at risk of delayed consultation, admission, and missing scheduled chemotherapy. We didn't have a proper telemedicine service in our center that time. Therefore, we used a Viber app, which is like WhatsApp, to communicate with patient and help them for the treatment. With this approach, no one missed scheduled chemotherapy, and the patients were very happy, and they even advised us not to stop this service after COVID pandemic, because they found it very, very easy and very convenient, and they found it very convenient to talk with their treating physician. So how to move forward to overcome all these challenges? I think we need to train more and more manpower, more and more manpower. We need more hematologists. We need probably more than 50 hematologists or hematopathologists in this country, and we can do that. We can reach that number only by training a new generation of physicians. We need government support to build more and more cancer centers all over the country. We need government support to promote our pharmaceutical industry. We also need government support to help to introduce efficient blood banking service in the country. We need more international collaborators like Dr. Damiano Rondelli to uplift our healthcare. And we also need the help of Nepali physicians who are working abroad. For example, like Dr. Gisal, for example, like Dr. Bisal Gewali. So Dr. Gewali is working very hard to improve cancer care in Nepal through his ASCO grant. Dr. Bisal and Karnal Academy of Medical Science a university based in a rural area of Nepal is introducing a one-year oncology program for our general practitioners. In Nepal, general practitioners are the real heroes because they are usually posted in the rural areas. They are the physician, and they are the only physician in that part of the in that part of the country. So one-year training of general practitioner in the field of oncology can help many patients locally and will ultimately help to improve patient outcome and reduce the financial burden of our patients. And finally, how we plan to tackle the financial burden. Well, so we have founded a U Foundation to tackle the financial burden, and we have founded it last year. U Foundation is a non-profit making organization, and it was basically a Dr. Damiano's idea. He was frustrated to see a patient paying huge amount of interest for the loans. At present, your foundation is working with local bank and government to fund treatment expenses of acute leukemia patient, and we hope this modality will help many needy patients and no one will be deprived of treatment. I would like to thank the organizers for giving me an opportunity. If you have any questions or queries, I'll be more than happy to answer it. Thank you. Thank you very much.
Okay, I think we are back together. I want to apologize to everybody. Hold on. Sorry. I think I have to stop this thing. I don't know how to do it. 1 second. Okay. I hope you hear me. I see two of my names on the screen, so I hope it's working. I want to thank. Actually, I think the other one is probably Dr. Poudyal, who's connected from Nepal. Bishesh, are you on the call?
Yes.
Hi. Great. So hi, Bishesh. He's connected with my link, so you see my name. But thank you very much, Bishesh. We listened and we watched your video. It was very well done, and thank you for your effort. You've been, I think, the history of medicine in Nepal owes you a special seat in the list of people who made a difference there. We welcome questions in the chat if anybody wants to ask question to Dr. Poudyal. I want to start asking you, Bishesh. No, you showed a lot of things that had happened in Nepal, a lot of efforts to put together a program that cannot be only done by one person, although you are the main actor, the main responsible for this. But how did you engage and involve other people in your hospital, your team, hospital, laboratory, doctors, nurses, to follow your dream?
Well, so it was not easy in the beginning, but later on when we started seeing many patients, and then when they understood how patients are suffering, how the patients are going, how because of unavailability of the treatment, and when they saw patients traveling to India or to the neighboring country for the treatment, then all of them got they became motivated, and then and then we started we just thought of starting hematology service, and all the motivated people that came around, and so it was like that. So it's I think it's when you don't have anything over here, and when you see the patient suffering, and then and patient dying in front of you, and I think that is the reason. I have not done anything, that this not, it's not like I have asked them to do this or to do that. It all came from within, that. So it's probably it's a it's a duty as a physician, as a medical, as a doctor. So that I think it's the feeling from inside to help the needy people. So
That's great. Thank you. So I know the questions is, I think we have a little bit of time. So and actually I'm asking you, and I don't know the answer, even if I've been to Nepal many times. Is there a cancer registry? I mean, most of the research and most of the advances in an epidemiology setting or in a population study that can be done in the country is based on data, reliable data on incidence and prevalence of cancer, every type of cancer. Is there a cancer registry that you participate in for the blood cancer, but that you're aware also of solid tumors in Nepal?
well, there are two types of cancer registry. One is hospital-based cancer registry, and another one is a population-based cancer registry. But we have our own registry. So last year we had an MOU with Queen's University at Canada. So since last year we are working on that registry, and so far we have our acute leukemia registry. So this registry is the hospital-based registry, and we are working with Queen's University at Canada for this registry.
Thank you. Another question, since I don't see other questions in the chat, but in regards of oncology in general, what is the status of screening and prevention and early diagnosis as efforts in your hospital or that you are aware in Nepal?
Well, there are many screening programs in Nepal, especially for cervical cancers. And because we don't do solid tumors, because I'm really sorry. I don't have I don't have I don't have an idea about it. But what I see and what I read from other hospitals, from other cancer hospitals, I believe that there are screening programs for cancer patients in Nepal.
Okay. Is there any question in the audience? I know that there's still a lot of people on the call. Well, one of the questions I have is another question, since I'm the one. So treating patient with the patients you are treating with cancer in general, but also especially blood cancer, people on chemotherapy, requires the connection and the collaboration of multi-specialty doctors, like from pathology to pulmonary to cardiology to pediatrics to a lot of people that work together. Do you know any? What's the status in your hospital?
Well, when we started, it was not that good, but now we are hiring more and more super specialty physicians. So we have neurologists and cardiologists and pulmonologists and nephrologists and critical care specialists. So so now we have different different specialties. But when we started, there were like we had only few. So now things are improving, and then now we have a good good team to take care of our patients.
So there's a question in the chat that I want you to answer. It's how did you identify Dr. Rondelli as an international partner or resource in your program?
Well, it's a long story. I mean, when we started our transplant program, and then as I've said, that we're looking for international collaborators. So I was, I was searching whether any other hospitals in Nepal are thinking, any other hospital in Nepal is thinking about starting a transplant. Then in the internet, I mean, when I was, I just saw the name of Binetara Foundation. And the Vinay Tara Foundation was helping Bharatpur Cancer Hospital to establish a transplant center. So I mailed the founder of Vinay Tara Foundation, and then he introduced me to Dr. Damian Rondelli.
There you go. And the rest is history. So another question from Steve Wine, the director of the Center of Health, is asking, can you describe further the family, social, and cultural challenges in getting individual patients and families to participate in BMT, and how did you overcome them?
Well, we haven't encountered many problems with the culture things. So for us, the main challenge, as I have said earlier, is the financial part. So when we talk to our patients, and when we tell them that they need a bone marrow transplant, whether regardless of ethnicity or cultural background, that most of them they follow what we say, and they agree. And that they usually are ready to to go with transplant. But the only problem here is the financial part, because of the financial thing, many patients know that they think twice whether they should go for a transplant or not. So culturally and the socially, there is no issues at all, because they adhere to a treatment plan, and then they follow what the physician tell them. But as I've said earlier, the most important barrier is the cost for the treatment.
Bishesh, following up on this question, I know from our experience actually, and I find these a little bit different from India, for example. So a family, when there's a diagnosis of patients with leukemia, with a cancer, or the need for a very expensive treatment, the family has to decide whether they can afford, whether the criteria they pick, whether to go forward and face a possible challenging financial toxicity and poverty afterward is based on criteria that every family has to decide. How many people are in the family, what the age of the patient, what are the chances of survival. And we talked about this before. So how do you see this, and how is changes in your experience across families and maybe background, ages?
No, well, it's so in Nepal, it is quite different from what is it in India. So here it's like, the fact, I've never experienced family denying bone marrow transplant because of because of other things. So for them, most important, as I've said, there's a financial thing is the most important thing for them. But when we talk to them, and then we ask, we defer them for a transplant, or we take them for a transplant, only few patients have deferred the transplant. They somehow manage the money from through the charity, as I've shown in my presentation, and it's so. I have not experienced those things in our patients. They almost everyone is like, they're eager to go ahead with transplant, and I have not faced those things in our practice.
Thank you. One more question. What do community education efforts look like in Nepal, especially since cancer diagnosis can be strenuous for not only the patient but family as well? So what is the community education initiatives that you have seen?
Well, well, when someone is diagnosed with cancer in Nepal, that's it's a very it's a because of the cost involved in the treatment and many other things, that patients and the patient relatives are very much stressed. And unfortunately there is no such social whereas you have what you call that, the social services, or things like that. So
Social
it's like
workers.
yeah, yeah. So it's it's a quite devastating experience for them when someone is diagnosed with cancer. But it's that everyone thinks and then when it's only about the cost of the treatment. That they are much worried about the cost rather than anything else. And but as I've said, that people are quite friendly over here. People are quite that most of the money for the treatment comes from the people who are working outside Nepal, because we have many our main income and our finance. I mean, our economy depends upon the remittance from the migrant workers. So they post. They're in the social media that they are diagnosed with the cancers, and they don't have enough money to
Okay.
and the people who are working abroad, they usually help these patients. They raise the fund, and then and the people and the patient gets money, and they come for the treatment. So in a community, it's it's not, I mean, we don't have that sort of social service kind of thing, or social things. So it's
Another question, actually, that is interesting and actually makes another difference with India, but it's based on your experience, outcomes and low cost. Have you considered promoting medical tourism to help raise funds?
not yet, because we are in a very early stage to do so, because of our infrastructure and many other hurdles. So we have not, that was where we thought about it a long time back, but we have not started yet.
Yes, and I can add a couple of things here. One is, as you said, there are only right now 2 rooms for transplant in the transplant unit that you have does not allow to increase by a lot the volume right now. But also to promote medical tourism, it requires an infrastructure of organization, and that's how India actually works. So I would expect, for example, that many patients from India would come to Nepal to have a transplant, because India, although is cheaper than here, but is probably double or more the cost for a transplant than what you have in Nepal. So, and that would create some political tensions between India and Nepal in your work.
Yes, so far we have transplanted two Indian patients and one Bangladeshi patient, and as I have said, it's way cheaper than in India and then in Bangladesh to get transplanted in Nepal.
So I'm very grateful. So I'm sure probably everybody knows that in Nepal right now the time is almost is 12:30 a.m. So Bishesh has been so gracious and nice to stay with us. Um, I would say there's another, probably one of the last questions that Steve is asking. How can this innovative work in DNT drive other advancements in global oncology? What do you think? How to replicate this model in other areas, in other setting of global oncology that you can imagine?
Well, I think that it all depends upon the collaborators. I mean, that if your collaborators is great enough, if they are willing to help, then this is very much possible. And believe me, I mean, that many other fields in medicine, in our hospital, they look to us, and that they come to us, and then they ask us many questions, like how can we how can we that how can we do the same thing that you are doing in Nepal, and can you introduce us to international collaborators who can really help us to improve our healthcare system. So I think, it's like it all depends upon the physician will in Nepal to improve the service, upon to whom you want to deliver it. So if other people, if other physicians in Nepal can get like we got from Dr. Damian Rondelli, I think that it's possible.
So, as we said before, I mean, UIC has many of people that are happy and willing to collaborate with anybody in Nepal. And we had this conversation before. We're trying also to sign an MOU with the college
Yeah.
with the med school there. Um, Please be aware that actually not only medicine but also through pharmacy, nursing, any kind of healthcare providers, there's a huge effort to support. So that's good. I want to also but make a comment on this. So in my many years there, it's been always a priority for me, and I think I learned this here at UIC. So I give the credit to the whole that the most important thing was not us, was not me. It was actually to make Nepal, to make you, to make the program there be in charge and be accountable and also get all the credit. And so it's all about people engaging and taking responsibility and with our support. So if there are no other questions, I think we can send Dr. Poudyal to sleep. And I want to thank everybody who joined this lecture. I apologize for the technical things that I'm sure that were caused by me. But I'm happy that we overcame these things here. I want to remind again everybody about next month lecture with Dr. Leonardo Cubillos, Director of the Center for Global Mental Health Research at the National Institute of Mental Health. And I am very grateful to all of you who attended, who asked questions, and to any follow-up questions, please let me know. And thank you, everybody. Bye.
Thank you, Damiano.
Bye, Bishesh.
Bye.
Good night.
Bye. Good night. Bye.